No? Okay, all right. Well, in that case, we'll go on to the last presentation. Dr. Kristi Warren in the Pulmonary the Division of Department of Internal Medicine.
Okay, I'll try not to stand too close to this mic. I'm actually a very loud person as it is. So, yeah, so thanks, Alfred, for inviting me, and thanks, everybody, for listening up. And I hope that you guys get something out of this little 10-minute talk. I'm basically going to give a crash course on sex differences in asthma. So, let me see, I got to make sure. There we go. So, oh, great. Okay. Yeah, I'll try not to talk too fast too. But yeah, so I'm going to just give a quick rundown of like our roadmap today is that we're going to go through kind of a background in asthma, just enough to get us all on the same page. I'm going to present this as it is a very female biased disease. So I'll give some background information on that, talk about our results from the Warren lab, and maybe a few other people's results peppered in there, and then finally give kind of a summary as we go, looking at the last couple slides of data. And yeah, so my goal was to use this project and present this basic science translational project as a way to kind of demonstrate this whole topic that we're on today, which is sex as a important biologic variable. So I almost always show this picture of asthmatic airway compared to a healthy airway. I think a lot of people know what asthma is, in terms of like kind of these maybe like the top, excessive coughing and then maybe this shortness of breath phenotype. But asthma is actually a really, it's a highly inflammatory disease. And what happens is let me see if I can get this to work. So in like a healthy airway, you kind of have this elasticity and you have airflow going in and out. But when an airway gets very blocked and damaged by this excessive inflammation, you end up having kind of like bronchoconstriction, airway obstruction, and then there's also this. So this is kind of like, I'm showing you this to kind of get to the what's going on inside the airways. It's not as simple as I think just excessive coughing, but yeah, shortness of breath, wheezing, and then also this mucus hypersecretion that occurs. And so we don't necessarily see that going on, but these are the symptoms that we're trying to prevent with our medication cocktails that are used. When it comes to what triggers these inflammatory events, it's often uncertain what triggers people. Some people know, other people don't. But we model some of these things in the lab. We use house dust mite, pet danders, things like that. And then when I was postdocing, I did a lot of work on upper respiratory tract infections and how those really drive this asthma to be like kind of this chronic inflammation. And that kind of feeds into what we've learned about upper respiratory tract infections in children. And this, what happens is in that first 2 years of life, there's this window of time where people are exposed to certain subsets of children are exposed to these severe respiratory infections. And this can actually feed into why those people develop asthma later in life. And then, yeah, so it's a very complex picture. Pollution becomes important. Allergen becomes important, these exposures. We also know that there's these hereditary factors that are playing a role in the development of asthma as well. My lab focuses on biological sex differences, and kind of the thrust of why my lab works on this is that we know that in adulthood that severe asthma is much more common in women in comparison to men. And when it comes to those like exacerbations that I talked about that lead to the airway obstruction and kind of these really bad inflammatory events, women are more likely to be hospitalized and they're more likely to end up in the ER because of their asthma exacerbation. So really important problem. When it comes to our understanding about, basically over the lifespan asthma development, males and females kind of have this prevalence in asthma that's very different in childhood. So boys are more likely to have higher rates of asthma, and then they essentially grow out of asthma. So as they hit puberty, asthma rates go down in men, and the opposite is true of females. So females start out at this lower risk of asthma, and then as they enter the reproductive years, they tend to have higher rates of asthma. And then, yeah, so basically what this is telling us is that the circulating sex hormones are most likely having a role in this. And this is a very, very simplified representation of a lot of different data. But trying to just sum it up for you, testosterone in almost all cases is protective in this response and also in viral infections. I know there was we talked about COVID a little bit earlier, what testosterone was doing in the COVID-19 pandemic, and testosterone was, I don't know, I won't go into that, but it was like, it's important basically in viral infections, right, in driving that anti-inflammatory response. So estrogen, in our hands, we've been able to show that estrogen is actually quite protective in our asthma models. It actually lowers the amount of inflammation. It actually improves, like, essentially the infiltrate that comes into the lung and prevents, basically those animals have better outcomes when we stabilize that estrogen in animals. There's a little bit of data that's out there that talks about estrogen and progesterone together and having this effect on promoting allergic inflammation. And I'll just highlight the estrus cycle for just a second here. So the reason that becomes important is because during this phase, you'll have basically estrogen and progesterone occurring at the same time. And so this paper from 2015 showed that these two were synergizing together and activating a very specific immune cell that drove the severe endotype of asthma. Progesterone we've also worked on during my career development award period. We showed that progesterone in this asthma model, in our animal models, actually promoted airway hyperactivity and then actually promoted the activation of these cells that I'm going to introduce next that we study. So we have a cell that we work on in our lab called the group 2 innate lymphoid cell. They are located in the airway. So I showed that airway earlier. This is actually just another image of an airway. This is a mouse airway. And what you can appreciate is that these little arrows are indicating where these group 2 innate lymphoid cells sit along the airway. And they basically are in a great location to be activated by the airway-derived cytokine IL-33. So what happens is these cells become activated and then they produce the cytokines IL-5 and IL-13, which are prototypical asthma cytokines. And so there's some biologics that are directed at these for asthmatics to actually help dampen down that inflammation usually. But anyway, so the takeaway message is that these ILC2s are in this like really prime position where they can, again, be activated. They then go on to drive a lot of these factors that contribute to that coughing, that wheezing. And one of the things that we've been questioning, or that we questioned early on, was if these cells are very involved in this asthmatic airway response, do they have anything to do with the sex difference that we see in asthma? So I've been working on this for about maybe like 8 years now, and this is again a very, very simplified version of our simplified graph of what our data shows, that female ILC2s, when you take them from a female host, they are far more activated in response to that activation cocktail of cytokines, the IL-33. So, and this is something we've reproduced now in about 4 different papers, I think 4 or 5 different papers. And what's also important about these cells is that ILC2s actually, I talked about how they reside along the airways where they can be activated by IL-33. Females actually have more of these cells in their airways. So not only are there more of them, they become more activated. So they make more of the asthma promoting cytokines. And then on top of that, they also proliferate more regularly. So they sit there and they double and double and they make more cytokine and more cytokine. And it really perpetuates that asthmatic inflammation. Okay. So again, done a lot of work on this. That was pretty much one graph summing our mouse data. Now we recently completed a clinical study at the VA here using, we recruited in veteran asthmatics during the reproductive years, so 18 to about 50 years of age. And I don't know how much time I have. I'll keep it pretty brief. But what we ended up discovering is that when we looked at males versus females and we just tried to do like an immune phenotype, and we introduced this new concept of like, they're trying to stratify asthma by endotype now. And two of the predominant endotypes are this type 2 high endotype where you see those eosinophilic responses in the sputum and the airways versus this type 2 low endotype where you'll get more of these neutrophil kind of non-specific inflammatory response. And this is actually the poorly controlled endotype. So these women do not respond as well to their medication cocktails. They end up in the ER more often, hospitalized. And so what our data showed was that, again, this is a very simplified definition, is that the eosinophilic type 2 high endotype was more common in the males versus the females having more of this neutrophilic endotype. We also discovered that there is this newer marker for ILC2s that is actually how the ILC2s will get from the blood into the lung. And what we were able to show by just doing a simple experiment measuring this marker is that these CRTH2 positive ILC2s were more not as often, we didn't find them as often in the blood. So what this is suggesting, and this was actually a suggestion from a reviewer from Frontiers Immunology, but what the data is suggesting is that these cells are likely on their way to the lung. And that's what this data means, is that more of these cells are trafficking into the lung of these females. And I'll say there is a new biologic coming down that is targeting this CRTH2. So again, just kind of summarizing as we go, what this means is that maybe this CRTH2 therapy is better for women, whereas that anti-IL-5 biologic might be better for males. So it's kind of getting at that precision medicine and why that's important. Okay, this is my last slide. This is our data where we tried to look at the hormone levels in these veteran asthmatics. And this is actually showing that we end up getting an inverse correlation. So when estrogen levels go up, we see our ILC2 numbers go down. So that fits with what we were showing in our animal model, in that estrogen is protective and driving these cells down. And I'll just point out this last graph here. So again, this is an assay that we do a lot in the lab where we take these cells, we activate them, they make IL-13, which is that asthma-promoting cytokine. When we co-culture with estrogen, we see a blunting of that response. And then when we block a very specific estrogen receptor, we lose that estrogen-associated effect. So we are working on this GPR1 pathway right now as a potential way to, actually the flip side of it, we're trying to activate this pathway and reduce the ILC2s and reduce their responses. So yeah, I'll leave it at that. I think I'm a couple minutes over. I can take some questions. I think that it's just about really highlighting the importance of hormones. Again, asthma is one of those diseases that we cannot ignore both sexes, or you have to have both sexes involved. And I even just sat on study section, and I can say that this sex as a biologic variable was it's every grant that has to do with ILC2s. All the reviewers are aware of it and asking about it. And I had a list of, we have lots and lots of people that help out. Sorry about the acknowledgements, kind of disappeared, but yeah, I'll take any questions. It's a lot. Thank you all.
Who has the
Really cool stuff. GPA, so that's the G protein coupled receptor, right? So it's GPA, yeah,
estrogen receptor.
yeah.
One.
It's the non-traditional receptors. So it's the membrane one.
Yeah.
So there's GPA knockouts. Has anyone ever looked to see if from what you're saying, if you don't activate it, if you activated the asthma is protected, but you'd see a change in the GPA knockouts with those cells?
There is a paper that is out where they tried to use the G1 agonist. I believe it was a G1. So,
Okay.
and they said that there was no effect on the ILC2s. And so it is going counter to what we're showing. Yeah. So we've been teasing apart this using simulating G1 or GPR1 ILC2s and transferring them into the mice that are RAG deficient and showing this activation of the asthma response. So there is a paper that is going against us right now, but they also did not, we've measured GPR1 on the ILC2s as well. So I still think it's important. It's just we haven't figured out the pharmacology.
And we showed that, in menopause, that actually the asthma got worse, which correlates with the
It
human
fits.
data.
Exactly.
So,
That's what I was thinking when you were
and we have the
talking.
JEPA knockouts in Tulane. Sarah Lindsay uses them for
Oh,
some
you
vascular
do?
work. Yeah.
Oh, very
So if you,
cool.
yeah, I can connect you
So
with
they,
her.
and my understanding is that they develop an obesity phenotype as well, don't they? Or is
I don't
that not?
remember. Yeah.
Okay. Which is why I kind of shied away from using them, because then it was, well, what about they're all obese and
Well, the problem with any estrogen knockout, I'm not sure about JEPA because it is a different one, but if you knock out the receptor, then the estrogen is super high because it
Right.
doesn't have that feedback.
yeah,
But
and
I
that
don't
has-
think that's true for JEPA.
we'll find out.
Excellent.
Not yet. That is a very, we are working on developing large data sets to get at some of this. So this is a small study. This was my career development award. You have a $75,000 budget to get it all done per year. So yeah, we're building collaborations, and yes, I would love to actually see that. But I will say that veterans are a very unique population. All these women developed asthma during adulthood, right? So that's really what's happening in the veteran population, is that they're seeing these deployment associated respiratory diseases, and women come back from deployments, they develop asthma, and it's happening more often in those female veterans. And obviously the female veteran population is growing. They're getting into that menopausal age as well. So, but I agree. But I do think they're a unique population, but it is very comparable, right? I think severe asthma, it kind of transcends that, whether or not you were an active duty military member. I don't know if that's helping answer your question. So.
Other questions?
Sure. Yeah, that's so there is big data out there. It's not from our country, it's from other countries that they've done these, because they had better health databases, I think. But asthma is onset is reduced if teenage girls go on to hormones, like birth control, things like that. That actually reduces asthma onset. And then there's I'm assuming that it is. Yes. Which fits with our data. I have not seen that yet, but I've been wondering. I always thought it was the estrogen component in those oral contraceptives that is the protective part of it. And then, but getting back to menopause too, there's a lot of data that shows that the hormone replacement therapy will improve lung function and asthma. So that's kind of the later end of the lifespan, but yeah, it seems to be protective. And I'll look for that progesterone data that just came out. Right. Or even I'm not saying that, like, I was just thinking about the women that deploy, is like maybe promoting oral contraceptives, just to help with those respiratory symptoms too, like almost like preventing the asthma onset. Is there any like role there? So, and that's, yeah. And I'm thinking about it from pulmonary. Right. Yeah. Very cool. Right. Thank you.
Okay, we have learned a lot about this morning from Dr. Brooks and everybody else about the importance of women's health, men's health, and how studying sex and biological variable can teach us not only about women's health, men's health, but also teach us about our basic physiology. So we heard from the panel discussion not only is it allowed, but it's strongly encouraged, and you must consider, right? Not necessarily doing both sexes, but consider sex as a biological variable in all your laboratory studies. So thank you very much. Now is a very important time, is lunch and poster, and be back here at 12:09.